treat it when we face the problem. But the most important thing, I think, the most important message I want to deliver today is that we need to prevent the tophus formations, okay, and to treat earlier gouty patients. So tophus, what is tophus? The definitions of tophus is the deposit of uric crystal in tissue. In fact, the term was initially used for clinical observations of these big depositions. So normally, it was used for clinical symptoms, clinical sign. And since 300 years ago, we know that tophus is composed by the concretions and depositions of uric crystals, and this was evidenced in, you see, 1684 by this guy who invented the microscope, okay? And this term now is challenged, in fact, by the current tools that allow to detect the crystal depositions, namely the ultrasound and also the DECT, dual energy CT. And we know that, in fact, the uric crystals can be detected by the ultrasound in asymptomatic hyperuricemic patients. And of course, at the late stage of the disease, of the gout disease, where the presence of the tophi is severe conditions of gouty patients. So this slide was shown by Pascal earlier. We know that the principal conditions to form crystals is the hyperuricemic, but hyperuricemia alone is not sufficient to the crystal deposition, because you see, even after 10 or 15 years of follow-up, only 50 patients with high hyperuricemic will develop flare or will develop gout. So this means that hyperuricemic level is necessary, but it's not sufficient. So there's other factors that actually is not identified. We know that the tissue, the alteration of the tissue is important, the pH of the tissue is important, and the environment, the temperature is important of the crystallizations. And so the main finding with the current tools to detect the crystals is obtained with the ultrasound and DEC. And we know from the ultrasound study that between 30 to 50% of asymptomatic patients had crystal depositions. So this depends on the site you will assess the crystal deposition, and it depends on the study. So we have, you see, between 25% here to 86% of patients with asymptomatic hyperuricemia who have, by ultrasound, sign of crystal depositions. So we know that what is tophus? Clinical tophus, we know that there's hyperuricemic is very important. We know also that the formations of the crystals is favored by the long durations of the gout disease. So if you don't treat the hyperuricemia in patients, you will have these patients with very severe disease with this tophus that we can observe by clinical examinations. So the tophus can be can be found in every area. It's the same area when where the patient experiences flare. So we will have the tophus on in the feet and also in hands. So it's a very severe patients. Then the elbow bursa and also the ear cartilage. And the presence of this tophus will lead to complications. You have local complications, but also systemic complications. One of the systemic complications, Pascal told us earlier, is the MACE and the cardiovascular disease. We know that the presence of tophus is very associated with a higher risk of cardiovascular events, but also of cardiovascular death. And the local complications is that leads to the presence of this tophi. It will lead to the disability. The patient will have impaired hand functions. We have, this is also, we will see that is associated with joint damage or bone damage. And this can lead for, in some case, to the fragility of bone and leads to the fracture. So when we observe histological examinations of the tophus or the tophi, we know that, in fact, the tophus is composed of multilobulated crystals separated by fibrous tissue, and these multilobulated depositions is surrounded by giant cells, multinucleated giant cells, but also macrophage, and these giant cells and macrophage had osteoclast-like phenotype, so probably the presence of these macrophage and these giant cells contribute to the bone erosion and to the bone damage. And what is interesting is that when we studied, in fact, the compositions of the crystals in the tophus, we were very surprised, in fact, to find that CPP crystals, so pyrophosphate crystal, we are very frequently found inside the tophus associated with the MSU crystals. And the presence of this CPP crystal in the tophi is increased with the aging of the patients, the long durations of the tophi, and also the long durations of the gout. So the presence of tophus is associated with local complications. One is the first complications or the first consequences is the impaired functions of the hand. So here, this is highlighted by these studies. We can observe that the presence, the number of the tophus in the hand is completely correlated with the several functional score. So this one, the Solomon score, assess in fact 20 items of the daily care of hand, the daily task of the hand, and each item is scored from 0 to 4. So the highest score is 18. And we can see that the presence is completely correlated with the decrease of the function of the hand, decrease of the grip strength of the hand, and decrease of the functionality of the upper limb. This is the questionnaire. The DASH questionnaire is the disability assessments of shoulder and hand, and we can observe that the presence of the tophus is completely correlated with the loss of functions. We know that the presence of the tophus is associated with flare. This is evidenced by a lot of work. So I just show you this one from one of my friends and colleagues, Tristan Pascard from Lille in France, who showed that the volume of the tophus assessed by DEC is one of the factors, the risk factors associated with flare. And the other work from the Italian colleagues, Eduardo, with using ultrasound, who show evidence that also here, the volume and the number of MSU depositions is very strongly correlated with the risk of flare. The presence of the crystal depositions is the main factors that drive the bone and the joint damage. And this was evidenced by a lot of work, and one of them is conducted by Nicolas Dalbet, using X-ray compared to dual to DECT. The DECT will assess, in fact, so the depositions of the crystals, highlighted here in green colors. And in this work, the different items of joint damage and bone damage, erosions, sclerosis, joint space So can we achieve to dissolve the crystal and the Top5 with usual care? So this is highlighted by this study. Also, Pascal also show you. So this compare treat-to-target strategy to usual care. The treat-to-target strategy is to adapt the ULT treatment until reaching the target. The adaptation is monthly down. The usual care, so the patients see the doctors, and when we see again 6 months later, and what the patients do with the drug, we don't know. So with this strategy, we observed that after 2 years, 88% of patients had a serum UL level under 300 micromolars, compared only to 70% in the usual care. And the main difference is, in fact, the mean dose of allopurinol. You see that to obtain the target, we need more than 300, 460 milligrams of allopurinol per day in this study, compared to the 230 milligrams per day in the usual care. And in this study, and when the patients reach the target, less than 300 micromolars, you see that the number of Top5 decrease. So the baseline, the percentage of patients with Top5 is 30.7%, and 2 years later, only 2.6% had Top5. So it means that effectively we can reduce this Top5, but again, the most important message is not to treat to target the Top5, but to prevent the occurrence of the Top5. So we need to treat earlier the patients, before the damage of bone was observed. And we need to have a lower target in order to accelerate the dissolutions. So thank you.